Good afternoon. In this short time of 15 minutes, I'll be discussing angular and translational vestibulo-ocular reflex. The objective of my talk is number one, understand the angular, that is the rotational, and translational, that is linear vestibulo-ocular reflex mechanisms. Secondly, to correlate vestibular and organ anatomy with reflex generation. And thirdly, interpret VOR in clinical context for ENT as neurology residents. Why look at eyes of dizzy patients? The reason is the evaluation of vestibulo-ocular reflex. The image that you see needs to be stabilized whether you are moving or the object is moving. We need to see clearly, the image must remain on the fovea. So, different eye movements, that is the saccades, smooth pursuits, vergence, vestibulo-ocular reflex, and optokinetic, are meant to get the image of an object fall on the fovea and to maintain it on the fovea by all these means. The owls can not move their eyes, so they move their head. They can rotate their head about 270 degrees. So even in the absence of vestibulo-ocular reflex, they have a very sharp eyes. Living without a vestibular apparatus or without a vestibulo-ocular reflex is like driving a bumpy road in Mongolia, which is shown here in this video. So you must be wondering why, if you are sitting in a jeep which is moving and getting these jerks, still you are able to read a newspaper. That is because of the integrate your vestibulo-ocular reflex. So semicircular canals, they act as sensors of angular accelerations. The rotational axes and the corresponding semicircular canals are shown here. Yaw, pitch and roll. In the yaw plane, the angular acceleration is detected by the horizontal semicircular canals. In the pitch and roll planes, the vertical canals, that this the posterior and anterior, they detect the angular accelerations. The excitatory and inhibitory projections are important. These are called the VOR pathways. And from the upper three, that is anterior, posterior, and horizontal, are the excitatory projections of the right horizontal semicircular canal, and the lower row shows the inhibitory projections of the three canals. It is important to note here that the excitatory projections of the left anterior semicircular canal and the inhibitory projections of the right posterior semicircular canal are to the same pair of muscles, that is the right inferior oblique and left superior rectus. Why I am telling you here? This is because a apogeotropic right posterior semicircular canal BPPV can sometimes mimic a anterior canal BPPV of the contralateral side. So these are the excitatory and inhibitory projections of the right-sided semicircular canals, right posterior semicircular canal, right superior oblique and left inferior rectus, that generates a slow phase VOR which is upbeating and left torsional. The positional nystagmus, which is a reflexive saccade or a fast phase VOR, is upbeating and right torsional. Likewise, the inhibitory projections of the right posterior semicircular canal are to the right inferior oblique and left superior rectus, generating a slow phase VOR which is upbeating and right torsional. The positional nystagmus in such cases is downbeating and left torsional. The right anterior semicircular canal excitatory projections are to the right superior rectus and left inferior oblique. The slow phase VOR is therefore upbeating and left torsional. The positional nystagmus is therefore downbeating and right torsional. The inhibitory projections of the right anterior semicircular canal are to the right inferior rectus and left superior oblique. generating a slow phase VOR which is downbeating and right torsional. Therefore, if such variant indeed exists, the positional nystagmus would be upbeating and left torsional. However, this has not been reported so far, so I am removing it from here. The excitatory projections of the right horizontal semicircular canal are to the right medial rectus and left lateral rectus, which generates a slow phase VOR during the right head yaw away from the right eye. That is, apogeotropic slow phase VOR is there, and therefore the nystagmus during the right lateral head roll in such cases would be geotropic, that is right in the right lateral head roll. Likewise, the inhibitory projections of the right horizontal semicircular canal are to the right lateral rectus and left medial rectus, generating a slow phase VOR which is geotropic. Therefore, the fast phase VOR, which is a reflexive saccade, is left and right lateral head roll, that is the apogeotropic. It is important to note that the slow phase VOR that is generated by the vestibular component as per the evolved law. The positional nystagmus, which is a fast phase VOR or a refixation saccade, is generated by frontal eye field and superior colliculus. It is important to remember here and revise that the excitatory projections in the vertical canals are ampulofugal and in the horizontal canal they are ampuloputal. Likewise, the inhibitory projections are ampulopetal in vertical canals and ampulofugal in horizontal canals. So why I am discussing VOR here in this topic in this slide is because the benign paroxysmal positional vertigo, it generates non-obligatory VORs, and that is the reason for the positionally triggered disease spells. So the rotational movements, they are roll like this, pitch like this, and yaw like this. These are being sensed by the three vertical semicircular canals. The sensors of linear accelerations are heave that gauges the motion in vertical axis as we go up and down in the elevator. Utricle, it gauges sway, that is around side to side movement, which is called sway, and anterior posterior movement, that is called surge, as we move on a walkaway on the airport. So this is the surge, this is the sway, and this is the heave. So linear accelerometers, they gauge these. The sensors of angular and linear acceleration in human beings, vestibular system and organs are semicircular canals, which are angular accelerometers, and otolith organs, which are linear accelerometers. True axial vertigo indicates an abnormality of semicircular canals or their central connections that process the signals from the semicircular canals. Floating sensation or tilt may indicate a otolith system disorder. So, the vestibular labyrinths are the paired structures. The central nervous system receives signals from both right and left membranous labyrinth and collates these signals. In the stationary head, the tonic discharges in both vestibular afferents are exactly balanced. During motion, the right and left membranous labyrinths are alternately excited and inhibited, leading to left-right difference in the vestibular nerve activity, which is recognized and perceived as motion. The humerus membranous labyrinth, the semicircular canals on the two sides, they exist in yoked pairs. That is, the right posterior semicircular canal is shares plane with the left anterior semicircular canal, and likewise the two horizontal semicircular canals also share the same plane. What is the advantage of sharing these planes is because they work in pair. When the right posterior semicircular canal depolarizes and increases its firing rate, the left anterior semicircular canal hyperpolarizes and decreases its firing rate to the same extent, and vice versa. Likewise, this holds true for the two horizontal canals also. When the right horizontal semicircular canal depolarizes and increases its firing rate, the left horizontal semicircular canal hyperpolarizes and decreases its firing rate to the same extent, and vice versa. So a state of no vertigo persists even if we are moving, we are rotating our head. So the blurring of vision, it occurs when the retinal image motion exceeds 1 degree per second, making a compensatory eye movement essential for clear vision. So what is definition? Angular vestibulo-ocular reflex is stabilizes the gaze during head rotation, which is known as a process called fixation or foveation. Corrective eye movement is equal in magnitude but opposite in direction to the disruptive eye movement. Foveation or fixation is essential for clear vision during daily activities. Sensory receptors, semicircular canals, as we said, angular accelerometers. Hair cells deflect and the ampulla generates neural signals, and canals work in push-pull arrangement as we saw in the two slides earlier on. Neural pathways is a 3 neuron arc, semicircular canal to the vestibular nerve, vestibular nuclei, and then abducens nuclei. Extraocular muscles via cranial nerves third and sixth. So example is head turn to the right. Right horizontal semicircular canal gets excited. The left horizontal semicircular canal is inhibited at the same time. Eyes move leftward to maintain fixation, and this is shown here by the horizontal semicircular ocular reflex. Here, high right head turn stimulates right horizontal semicircular canal, vestibular nucleus, and then third and sixth nucleus, and there is a movement of the eyes to the opposite left side. VOR gain is defined as a ratio of eye velocity to the head velocity. Ideal gain is approximately 0.8 to 1.0 in yaw and pitch planes and 0.5 to 0.7 in roll plane. Adaptable through cerebellar mechanisms. Clinical testing, head impulse test, video head impulse test, rotational chair testing. So the slow vestibulo-ocular reflex, which is also called the visually enhanced vestibulo-ocular reflex or VVOR, it evaluates the central integration of the vestibular, visual and smooth pursuit systems during slow head movements, and in fact it tests the central disorders of vestibular system. Here the Daniel Gold is testing horizontal as well as the vertical VVOR. The head impulse test is here. Unpredictable jerks. Clinical significance: reduced or asymmetric VOR indicates peripheral vestibular dysfunction. Absence of corrective saccades during the head impulse test suggests a normal angular VOR. Commonly affected in vestibular neuritis and bilateral vestibulopathy. Hereditary degenerative ataxias, posterior circulation stroke, multiple sclerosis, and in traumatic brain injuries, they may be affected, but they are not clinically diagnostic. Summary: angular VOR ensures gaze stability during rapid head rotation. It is mediated by semicircular canals and brainstem circuitry, clinically testable and adaptable reflex. Translational VOR, clinical physiology and relevance. Definition: translational VOR, tVOR, stabilizes gaze during linear head movements. Eye movements compensate for head translation rather than rotation. Critical for the near vision stability. Sensory receptors are mediated by the otolith organs, that is utricle and saccule. Utricle detects the horizontal linear acceleration while the saccule detects the vertical linear accelerations. Stimulus characteristics: response to linear acceleration. Eyes respond scales with viewing distance, more important for near targets than for the far targets. Neural pathways: otoliths to vestibular nerve, vestibular nuclei integration, and projections to the oculomotor nuclei. Difference from the angular VOR: angular VOR, semicircular canals and head rotation. Translational VOR, otolith organs and linear motion. The example of translational VOR, as you are moving up and down in the elevator, or in the airport you are moving on a automated electrical walkaway. tVOR requires distance dependent scaling. Examples of forward head translation: head moves forward during walking, eyes rotate downwards and inwards, maintains fixation on near objects. Clinical testing: head heave test, that is the only test which is clinically available on bedside to test the translational VOR. Ocular responses during sled testing: motorized linear sled for foreft, lateral and vertical translation, that is limited to the laboratory testing. Dynamic visual acuity during linear motion also tests the translational VOR. Indirect assessment of the otolith dysfunction can be done by the vestibular evoked myogenic potential. So, clinical significance of the translational VOR TVOR is: TVOR stabilizes vision during linear head movements such as vertical motion during walking. Unlike the rotational VOR, that is the angular VOR, TVOR primarily reduces the relative retinal image motion rather than perfectly fixing gaze on a near target. Normal translation VOR gain is around 0.5 to 0.6, and this is sufficient for functional visual stability during daily routine activities. Failure of tVOR modulation for viewing distance indicates otolith related or central vestibular dysfunction. Impaired tVOR responses are observed in cerebellar disorders and progressive supranuclear palsy. Clinical assessment of tVOR helps detect subtle vestibular deficits not revealed by the rotational or the angular VOR testing alone. Clinical significance: impaired in otolith disorders. Patients complain of visual blur while walking, seen in bilateral vestibulopathy as well. So, this is the head impulse test, courtesy Dr. Walter.
Is a test for the horizontal canal, the superior vestibular nerve, and it's the head impulse test. So again, you want to be about arm's length away from your patient. Keep your eyes on the tip of my nose, Kelly. Big hands above the ears, firmly on the skull. And keep your eyes right on my nose. Tip the head down about 20-30 degrees. Get her to relax, and then an unpredictable thrust. And after the thrust, you're observing to see if the patient's eyes are on the tip of your nose. This needs to be done in an unpredictable manner so the patient doesn't know which way you're going to go. So that's a head impulse test. The test we're going to demonstrate is the heave test. It's a test of utricular function. So we're going to have the patient with the tip of my nose. It's helpful to have the patient drape their hands over your forearms. And just keep your eyes right on the tip of my nose. Good. You just apply a translation to the head. Good. Compare left to right.
So, the summary is: translational VOR stabilizes gaze during head translation, depends on otolith organ integrity, clinically relevant for near vision during locomotion. Finally, I am deeply grateful to my friend and mentor Professor Sudhir Kothari for kindly sharing slides 2 to 7, 12, 14, and 26 and 27, and all his guidance and mentoring that he has done during last 20 years. Thank you very much. I finished my talk here.